Everyone stand by. We are live in 5, 4, 3, 2, 1.
Uh, Good evening, everybody. This is our regular live session. Today, we are discussing little different, the much more important rather. That is mass for
Everyone
abdomen.
stand by. We are live.
I welcome Professor Muthukumar sir from Savita Medical College, Professor and HOD. I welcome Professor Keshav Prasad. He has just joined. He will join again from Sullia Medical College. I welcome Manoran sir from Manukula Medical College from Puducherry. He will join. And I welcome students from Kasturba Medical College, Mangalore, final year students, Mr. Arjun Singh and Srivasav Tota. And I welcome all students who joined through YouTube for this important discussion because it's a long case in the abdomen, and regularly there will be one case will be there for UGs and of course PGs also. So how to present, how to discuss, whatever these things are quite important. So we'll, without wasting time, straight away, sir, Muthukumar sir, will straight away
Yes,
go.
sir. Yes, we can proceed, sir.
I think so. Srivas is presenting the history. Over to Srivas sir.
Good morning to all the professors here. Thank you so much for this, and also thank you so much, SRB sir, for this opportunity. With that, I'll begin the presentation. First, our case is about Mr. X, a 35-year-old male hailing from Chikmagalur district, Karnataka, a manual laborer by occupation, from the upper lower class as per the modified Ubuswami scale. He had come with the chief complaints of pain in the epigastric regions since 2.5 months and swelling in the epigastric region since 2.5 months. History of presenting illness. Patient was asymptomatic 4 months ago, after which he developed upper abdominal pain, which was sudden in onset, severe, continuous in nature, which radiated to the back, exaggerated on having food and lying supine, and was associated with multiple episodes of nausea and vomiting, for which he was admitted and was conservatively managed for 1 week, during which his pain subsided. Patient then stated that 1 week after discharge, he again developed pain in the epigastric region, for which he was operated on, details not known, after which he was discharged. Then, the patient noticed a lump 2.5 months ago in the upper abdomen, which was insidious in onset, gradually increasing in size to its current size. It was associated with pain in the epigastric and the left lumbar region, which was insidious in onset, gradually progressive.
Sir, good evening, sir.
Good evening, sir. Namaste, sir.
Namaste, sir. Namaste.
Muthukumar, sir. Good evening.
Thank you, sir. Continue.
Yes, it was associated with pain in the epigastric and the left lumbar region, which was insidious in onset, gradually progressive, increasing in severity, dull aching and cramping in nature, radiating to the back, which aggravated on eating food and relieved on taking pain medications.
On your next slide. Srivas sir, next slide is on actually.
Sir?
Next slide is on.
Sir, I'm not able to move, sir.
You can see. You can see.
Yes, I can see, sir.
Okay, continue.
Yes. There was history of loss of appetite and weight loss of 11 kilograms over 3 months. There was history of heartburn and regurgitation of food. There was history of multiple episodes of nausea and postprandial vomiting. The vomitus consisted of food particles and was bilious. There was history of constipation. There was history of yellowish discoloration of sclera and mucous membranes.
Next slide.
Yeah. There was no history of trauma to the abdomen. There was no history of gallstone pathology. There was no history of any other swellings. And there was no history of fever, hematemesis, melena, or any other systemic symptoms. Past history, patient is HbS-Ag positive, no history of diabetes, gallstone pathology, hypertriglyceridemia, hypertension, thyroid dysfunction, or COPD. No history of any drug intake such as sulfur drugs and NITIs, no history of any allergies, and no history of blood transfusion. Family history, no history of any malignancies in the family and no history of any similar complaints in the family, and the family tree is depicted. Personal history, patient consumes a mixed diet. Patient currently has reduced appetite. Patient has reduced and disturbed sleep due to the pain. Bowel habits are altered. Bladder habits are normal. Patient consumed alcohol regularly for 10 years, starting at 25 years of age, and he stopped when his symptoms worsened. Patient used to consume 300 to 360 milliliters daily. A patient also consumed Gudka for 2 years, starting at 25 years of age, and stopped at 27 years of age. There was no history of smoking. Summary of history: a 35-year-old male had come to the government Wenlock hospital with complaints of swelling and pain in the epigastric for 2.5 months with history of acute pancreatitis, which was managed initially symptomatically and a week later surgically. He is HbS-Ag positive and he has history of alcohol intake for 10 years.
We'll go back to the.
That's right.
Okay, next. Sir, anything to comment on this? No, sir.
Can you use epigastric region? When you mentioned about complaint. You cannot use technical terms, epigastric and other things. You have to say upper abdomen.
Yes, sir.
Right side, right upper abdomen, left upper abdomen.
Okay, sir.
Both complaints started simultaneously.
Sir, pain preceded the swelling, sir.
Pain preceded the swelling.
Which came first?
Pain, sir. Pain.
Epigastric pain. Okay.
Yes, sir.
But
What is
there
it?
must some gap between the pain. There must some gap between pain and swelling.
So what is the time interval between the onset of pain and appearance of the swelling?
Sir, we asked the patient, but he was not able to differentiate exactly well. He told both 2.5 months ago, and then I asked him which one came first. He told pain, but patient was not able to tell which came first, like the exact time.
There was a surgery also, no, in between.
Yes, sir.
There was a surgery done, sir. Correct. What happened? The surgery was done for the swelling or for the pain?
Sir, he told that 1 week after he was discharged from the hospital, he had again started developing pain, and he was taken.
No, listen, very carefully. First he had pain. Then after 1 week of pain, he was operated.
No, sir. First he was conservatively managed for 1 week, after which he was discharged, and then he was operated 1 week later.
Fine. After 15 days, when he was operated, was there a swelling or there was no swelling?
We don't know, sir.
No,
That is the most important point here.
So the history, in continuity. There's a gap in the history. It is
So
very
both cannot start simultaneously. Isn't it? Something started first, followed by some other next event. So you only said pain started first. Swelling started subsequently. So there must be some interval, time interval
Some gap
between the two.
gap. If you the history, you would get.
Pain, patient can easily appreciate. But swelling, if it is big only, they will appreciate.
Correct.
Yes.
So swelling should be the later only, not at the same time. Unlikely to be same time. If you take proper history, you'll be able to make it out. Okay. So better to put as upper abdomen, because in patients
Yes, sir.
can
The swelling started 1 week after the surgery. That means total gap was about 3 weeks between the pain and surgery. So it can't be same.
Okay.
Next slide. Next slide. Anything to comment on this, sir? Come on, Keshav.
The Joseph, I don't know whether you are, obviously all the things started after the change of alcohol.
Sorry, I couldn't get you, sir.
We can't hear you.
All the history, all these episodes have started after the change of alcohol. After one episode of consuming heavy alcohol, that history is missing.
Sir, I'm so sorry. I'm not able to. Your voice is breaking.
Any history of drinking alcohol?
Yes, sir. The patient was an alcohol, like a patient was a drinker of alcohol, and he stopped when the pain stopped.
Before this episode, before he suddenly developed pain, did he consume use of alcohol?
Sir, it has pain started after the intake of alcohol.
Sir, yes, sir. He stopped drinking alcohol after the pain started. So yes, he was drinking alcohol after the.
The pain precipitated by alcohol or not?
One episode, was it one episode?
That sudden onset severe. So before that, what happened? Following intake of alcohol, it developed sudden onset, or by itself it started?
Whether just before pain started, whether he has taken previously alcohol or not, because usually such things happens after a bout of alcohol intake.
Alcohol,
Yes, sir. Yes, sir. Yes, sir. This happened after alcohol intake. The episode started after alcohol intake.
So that you should mention sudden onset following intake of alcohol, which is severe, continuous in nature, radiated to the back. Okay, all that is pointing towards what?
So it's pointing towards an episode of acute pancreatitis.
Of course.
Pancreatic pain. Pancreatic pain. Exaggerated by food, identified. Any relieving factor for the pain?
Sir, we asked him if when bending forward, if it's relieving, but he told it was he felt nothing. He didn't feel that.
Yeah, in that case, you can expect no relieving.
Sir?
Conservatively manage forward.
Yes.
Because it's 1 week after discharge. So whether he has taken alcohol again?
No, sir. No, sir. He told that after his first episode, he did not take alcohol. He did not touch alcohol since then.
After surgery, he became all right. Pain has subsided.
Yes, sir. Until 2.5 months ago, he was fine. He was completely asymptomatic at that moment.
Was fine. Was asymptomatic. Okay. We'll go to next slide, sir. Next.
Yes, sir.
Sir, sir. Next slide. Why not radiating back?
Sir, that could be possibly because of irritation of the retroperitoneal nerves. That could be one reason because of which the pain is radiating towards the back.
Why pancreatic pain radiates back?
So, because of the irritation of the retroperitoneal nerves.
Retroperitoneal?
Sir?
Retroperitoneal?
Yes.
Splanchnic. One is inflammation, another is ductal dilatation, and third is nerve irritation. Okay? Okay.
Yes.
Sir, anything to ask Muthukumar, sir? Sir? Sure. Next slide. Next. One in why constipation, Srivas?
Sir, the pseudocyst could be compressing the different parts of the alimentary canal, because of which there could be obstruction to the passage of food, because of which the patient may have had a sense of constipation.
No, he has got multiple episodes of nausea, postprandial vomiting. So whatever he eats, he is throwing out. Then naturally there will not
Yes,
be
sir.
Dehydration, no?
Yeah,
no
also he must have, yes, sir, because of low food intake also.
everything is coming out.
What is the cause for yellow pigmentation?
What is the time?
Sir, because there could be obstruction to the obstruction distal to the second part of the duodenum. So because of that, and also it could be compressing the common vent duct. So because of that, it could be present with symptoms of obstruction.
When did he have this jaundice?
Sir, jaundice he's been having since 4 months, he told. But it could also be due to his status of HBS AG positive.
No, you are air job.
Srivatsav,
Yes, sir.
you will go line by line. First line is what?
Yes,
Weight loss for 11 kgs over 3 months. What does it mean to you?
yes, sir.
What does the
Sir, because of the multiple episodes of nausea, vomiting, he told his appetite reduced, so that could be one of the reasons for weight loss.
I want to know whether it is significant or not.
significant or not?
Yes, sir, it is significant.
You mean to say that is just because of vomiting alone? 11 kgs.
Sir, also due to less food intake.
If you are mentioning 11 kg, you have to mention the weight of the patient.
Oh, okay, sir.
Then only we can assess.
Okay.
In which other condition you will get such weight loss?
Sir, it could be due to cystinocarcinoma of the pancreas. In that also there could be
Some
malignancy.
malignancy.
Any malignancy loss.
Some malignancy. Okay. What is this history of heartburn and regurgitation of food? What does it tell you?
Sir, because of the obstruction, because any mass out there could be obstructing the gastric outlet, because of which there could be regurgitation of food.
No. You first of all you come out of that pseudo-cystic obstruction. you talk with the open mind. Okay. You got a preformed this thing that pseudo-cyst is there. Second part is compression. That is why he is not eating. So let it be there. But your discussion is open, so you have to think of other things.
Other things are discussed.
Yes.
Why heartburn and regurgitation? That's what sir is asking.
Sir, he has a history of alcohol intake, because of which there could be gastric ulcers also. That could be one more reason.
No. Alcohol-induced gastritis, APD,
Yes,
reflux esophagitis.
Reflux.
So all those things. Acidity by itself. All those things. Okay. Multiple episodes of nausea and postprandial vomiting. Is there anything you have to ask? What is the interval between the intake of food and vomit? Why it is important?
How long after taking food he develop vomiting? Immediately after taking food?
Sir, he told immediately after taking food he used to vomit. Shortly after taking food.
After each and every food, or episodic it is?
After food intake.
Regularly, every day he used to get vomiting, or
He told whenever he took food, sir, he used to vomit.
Srivatsav, you have to elaborate. You have to ask him. If you swallow, then how long later you take vomiting? Immediately it comes out, or after 10 minutes, after half an hour, after 2 hours. So all that gives some clue, the site of obstruction. So he said immediately means that is patient's history. So you have to ask him how long, suppose he eat breakfast means then 8 o'clock, immediately in 8 o'clock, 8:05 you will vomit, or after 10 minutes, 15 minutes.
or after half an hour he'll vomit.
After half an hour or something. So that question you have to ask. Why you should ask that?
Why it is important?
Duration. Why it is important?
Timing of
So it
the
can be if the patient has any swelling, where is it compressing? If it's compressing down, that means there's enough time for the food to reach down, then it regurgitates. Or if it's compressing at the upper level ventricle, there'll be immediate regurgitation of food. So it tells us where the compression of the ventricle is.
Upper GI esophageal obstruction immediately after
It's
food.
just stomach or duodenal.
Okay, gastric outlet is after some interval. Okay, so that is the clue you have to ask. Okay, then history of constipation, we know that nothing is going down.
Whenever you mention one complaint, you have to mention the duration.
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 Duration you have to mention. You have not mentioned, yes, sir. Important.
Duration you have to mention. You mentioned bilious.
Yeah.
Is it blood stained or not?
So it was not blood test.
It was not
That you
blood
got to
stained.
mention. That you have to mention.
Yes.
Okay.
As Dr. Manoharan mentioned, you don't concentrate only on pseudosis.
You have to mention.
What does that word bilious vomiting mean to you?
So that it will be green color, green in color. Green.
What is the important, clinical importance?
Somebody vomits without bile, somebody vomits with bile. Is there any importance?
What is your interpretation?
So that food, that means the food is able to reach the part where the common bile duct is entering the duodenum. After which, so that means it's lower, something involving the around the duodenum, below the duodenum.
Bile is secreted where?
Sir, it is secreted from the gallbladder and goes down the biliary tract and opens up into the second part of the duodenum.
Second part of duodenum. So bile is. So that means bile is entering the stomach, and then
No,
he is
sir.
no. That means he is vomiting. You only said no.
Bilious vomiting.
Bilious vomiting.
You only told bilious vomiting.
Bilious vomiting means bile is entering the stomach. That means antrum is open or closed.
Gastric outlet is open or open? Otherwise, why is it?
That means the gastric outlet is open.
Open.
Or it is not completely affected.
It's not affected.
Partially affected.
Okay.
Not completely affected.
Okay.
So
Yes.
what does the last line? Last line mean to you?
Discoloration.
So there was history of yellowish displacement sclera and mucous membranes.
Probably.
So yes, sir, it was jaundice.
Patient is jaundice. Next slide.
Next slide. Trauma. Why you wanted us trauma?
Trauma, sir, because trauma is one of the cause of acute pancreatitis. It could be one of the etiological factors.
Gallstone pathology.
Sir, gallstone pathology is the most common cause of acute pancreatitis.
Okay.
Hey, I just wanted to know, see, you are telling trauma is a common for acute pancreatitis. We have not thought about pancreatitis now. Again, everything you are focusing only on pancreatitis.
Already we have thought of, already had a diagnosis in your hand.
See, trauma can give rise to a big hematoma. That can also give rise to an epigastric mass.
Epigastric mass,
You are
yes.
not thinking about that.
Blood injury.
I think trauma is causing pancreatitis. Which is more common, hematoma or pancreatitis?
Hematoma.
Hematoma.
Then you are thinking,
History, asking history is not a problem. Telling it is only pancreatic disease, pancreatic injury is wrong. Injury cannot be anywhere. Okay. So, don't think only pancreatic. You have to conclusion. You are everything telling about English only. So that's what Malone sir is telling. Think widely. Okay. He said pathology is not there, but he said the jaundice is there.
and you told jaundice is from 4 months, before all these episodes.
Yes, sir.
Jaundice is
So that could be possibly because like he was HbA1c positive. That could be one of the causes.
HbA1c that's positive does not mean a person will be jaundice. It is just that he is HbA0 positive. That has nothing to do with jaundice.
there. There are everything.
Yes.
Okay. Time of infection, they will have jaundice now. They will not have jaundice positive. They will write down positive, you know, they'll be. Doesn't mean they will have jaundice. Okay. So,
Why do you ask about history of fever?
if you have fever, why?
Sir, fever could be because it is fever. Like if there's any, it could be a like anything as a cyst or any cyst or any other pathology could be complicated by fever, or even if there's a swelling or a.
Any inflammatory conditions can cause fever, no acute inflammation.
Yes, sir. Yes, it could be the inflammation of the common bile duct. It could be inflammation of the
Maybe cholangitis.
any cholangitis.
Okay.
Why hematemesis? Hematemesis.
Why hematemesis? Suppose in a pancreatitis patient only, why hematemesis?
So it can cause it may affect the splenic artery. It can cause splenic vein thrombosis. It can cause pseudoaneurysm of splenic artery, which can present as hematemesis in the patient.
Portal hypertension.
Okay. Okay.
Okay.
They may be having endothelial portal hypertension. And
Yes, sir.
because you are told already patient was consuming alcohol regularly, no?
Alcohol esophageal viruses can also rupture. Yeah.
Okay. Okay.
It's
So
like-
we should be able to give reason why we want to ask this history. You were able to scientific reason why you are asking the history. Every word, every sentence you are telling, no? You should be able to give reason. It is the important thing.
So you say that patient is known alcoholic, so probably patient has gone for cirrhosis.
Cirrhosis.
Cirrhosis liver causing portal hypertension that may lead to hematemesis.
Hematemesis.
Isn't it? So that like that, you correlate like that. Next slide. Next slide, please. Hypertriglyceridemia, hypertension.
Okay.
Okay.
Most of diabetes, pathology, hyperlipidemia, hypertension, thyroid dysfunction, no history of any drug intake, no history of any allergy, no history of blood transfusion. Okay, sir, anything to comment on this?
Nothing, sir.
Okay.
Next slide.
Next. Okay. Sir, anything to comment? No. Next slide. Diet currently when reduced disturbed sleep habits, bladder, consumed alcohol. That is important issue actually. Only 2 years he was consuming gudka, is it? Only
Yes,
2
sir.
years.
Yes.
Okay. No history of smoking. Okay. So next slide. Next slide. Next. Okay. We'll go to the examination, sir.
Yes, sir. Yes, sir.
Summary. Just see the summary.
Summary, sir.
Go. Okay. Summary. Anything to comment on?
35-year-old male.
Anything to comment? That's all the things we have discussed actually. We'll go to examination, sir.
Yes, sir. Yes, sir.
Yes, sir.
Next slide. Okay.
Yes, sir. Yes, sir. Am I audible, sir?
You're audible.
So I'll be talking about examination, general physical examination. Consent was taken. The patient was examined in a well-lit room. The patient was conscious, cooperative, and well-oriented to time, place, and person. The patient appeared poorly built and inadequately nourished. The vitals were as follows. The pulse rate was 82 beats per minute with regular rhythm, rate, character, volume. No radial or radiofemoral delay. No vessel wall thickening, and all peripheral pulses were felt. The blood pressure measured in left arm sitting position was required to be 110 over 60 millimeters of mercury. Next slide. The respiratory rate was 16 cycles per minute with evident abdominal thoracic bleeding. The temperature was afebrile at time of examination. No pallor cyanosis, clubbing, lymphadenopathy, edema was seen. However, icterus was present in the upper palpebral conjunctiva. Coming to local examination of the mass, in the inspectory findings, the patient was examined in supine position in a well-lit room. The abdomen is not distended, but there's a fullness noticed in the epigastric region. The umbilicus was central in position and inverted in nature. All quadrants moved equally with respiration. There's an old operation upper midline scar seen in the abdomen, which was healed with secondary intention. Scars of old drain placement of 1.5 centimeter size each was seen on either side and above the level of umbilicus. There's no pigmentation, no dilated veins. The flanks look normal, they were not distended, and the hernia orifices were intact. Palpation, inspectory findings were confirmed. Local rise of temperature was present. Describing the mass in the epigastric region, a tender mass is palpable in the epigastric region. It does not move with respiration. It has got well-defined borders, smooth surface, soft in consistency over the center, and firm in the periphery. The lower border is well rounded. Coming to the size of the mass, it was 10 by 12 centimeters vertical into horizontal. The upper border was 7.5 centimeters from the xiphisternum and lower border 17.5 centimeters from xiphisternum and 3 centimeters above the umbilicus. The mass did not have any intrinsic mobility of its own, but on checking the transverse pulsation was positive on deep palpation. On head raising test, the mass was found to be intra-abdominal retroperitoneal. The mass did not change location, did not fall forward in changing the position of the patient. This video was done to elicit the transverse pulsation of the patient. The patient assumed a knee to the chest position, and then we put the index finger on the mass, and a transverse pulsation was felt on deep palpation of the mass. Next slide, ma'am. On percussion, liver dullness was noticed in the right fifth intercostal space in the right mid-clavicular line. A general tympanic node was noted all over abdomen, but the mass was dull. There's no signs of ascites. Auscultation showed bowel sounds were heard. Left supraclavicular lymph node was not palpable, and per rectal examination was normal. Other system examination, respiratory system, normal vesicular breath sounds were heard without any added sounds of pleural effusion. In cardiovascular system, normal heart sounds were heard without any added murmurs. And in central nervous system examination, there's no focal neurological deficits and the spine was normal. Summary of the history and examination. Ma'am, I can't see the slide.
No, the slide is not seen. Lavanya?
Summary, a 35-year-old male came to Government Mental Hospital with chief complaints of swelling and pain in the epigastrium for the 2.5 months duration with history of acute pancreatitis, which was managed initially symptomatically and a week later surgically. He is also HBsAg positive. He has history of alcohol intake for 10 years. Upon examination, icterus was present. An epigastric swelling was noted, which is 10 by 12 centimeter in size and dimensions, tender in nature, well-defined but irregular borders, tense with smooth surface and soft consistency in center, but firm in the periphery. Other systemic examinations were normal. So based upon the history and examination, and considering that the patient had a past episode of acute pancreatitis, the provisional diagnosis we assume is pancreatic pseudocyst in this patient.
I will go back to the examination.
Yes, sir.
Here one. Sir, anything to comment on this, sir?
Next slide.
Better examination, nothing, sir.
Next slide.
Next. Yes, present.
Next slide.
Next slide. And about this examination, the inspection,
In this picture, you have drawn an outline, no? Round outline. That is the mass.
Yes, so that's the mass we felt on palpation. Like that's what we assume that the borders to be of the mass in the epigastric region.
Because you told me it is 3 centimeters above the umbilicus.
Yes, when you the original size is that, but on palpation when I felt it felt this dimension of size. Like the firmness and dullness is more in these areas.
It is actually just above the umbilicus, not very.
Yeah, it's just above the umbilicus. Not just above the umbilicus.
Very high. How you want to look for dilate? How we look for dilated veins?
In supine position, you look for dilated veins.
How we look for dilated veins? Standing or supine?
Standing position.
Standing position.
Yes, we mentioned that.
So there is a mass in the epigastric region,
Yes, sir.
right? We don't know whether it is from pancreas. What are the other anatomical possibilities?
If it's in the epigastrium, it can be a left lobe of the liver involvement, having a cyst in the left lobe liver. It can be a stomach or gastric involvement. It can be a retroperitoneal mass or a pancreatic mass. Talking about vessels, this can be a abdominal aneurysm can also be present.
So if he says pancreas, I will ask you why it is not liver. Why it
Sorry,
is not
sir?
spleen. If you say it is arising from pancreas, I will ask you why it is not from liver or spleen or some other section. So you must be in a position to tell the reason for it.
Sir, if we think it's a liver mass
We
or a
will
left,
do it. We will discuss it later. First we will
Okay.
finish it. Finish up.
Okay. Manoj,
Yes, sir, Arjun.
yes, sir.
So you are seeing a mass. This is inspection, no?
Yes, sir.
Is the mouse moving with respiration or something?
The mass is not moving with respiration. The mass did not change its position with the respiration of the patient.
Where you are not mentioned anywhere.
So it
Any
was.
You said all.
Pulsation visible?
No, you said all quadrants move equally with respiration. The marks is moving or not? What, Arjun? Understood?
Yes, sir, the mass did not move with respiration. It did not move with
You
respiration.
have to mention specifically because that's
Yes,
why
yes,
Sir is asking. Epigastric mass, you only said left lobe of liver, isn't it?
Yes, yes, yes. That would move with respiration. Yes,
That
yes.
is the epigastric region, so all structures is moves. Even if it is a gastric dilated stomach, that also will move with respiration.
Respiration.
Liver mass will move with respiration.
Yes,
Sir
sir.
asked you, why it is not why it is pancreas?
Yes, sir. We
In
had
the pancreas-
mentions in the palpation. We'll write an inspection.
Palpation.
also.
Palpation we will discuss. Pulsation, is it visible?
The pulsation was not visible. Only when I did the transfer pulsation test, it was felt. It's not
Is
visibly
it visible
seen.
in pseudocyst of the pancreas?
It's felt on transfer pulsation. Yes, sir.
It is visible.
Okay, sir.
If it is in the epigastric region, it is visible.
Okay,
this-
sir.
Then, for completion's sake, you can mention about renal angle also, fullness.
Okay,
Fullness.
sir.
Don't concentrate only on the anterior aspect. Go to the posterior
Okay,
aspect. Mention about renal angle, though fullness.
Yes, yes.
So movement with respiration is inspectory finding only.
Yes, yes. I will write an inspection. Yes,
Huh?
sir.
Right. Good. Next slide.
there's also check cutting the palpation, but inspection you have to mention. Important
Okay, sir.
movement with the respiration.
Yes, sir.
Okay. Okay. Palpation, anything to be moving in the, it is not moving in the respiration, got well-defined border with surface, and there is a center or rounded.
Upper border is upper border.
Upper border,
So the lower border was well felt. The upper border was not well felt. Only the lower border was well made out. It's round curve in a border.
upper border is not well felt. What
Upper
about
border was not well defined on examination.
No, is there a gap between your costal margin and the upper border?
upper border?
Yes, sir. When we tried to insert the fingers between the coastal margin and the mass upper border, you could insert the fingers. So the gap is present between the coastal margin and the mass.
Right side or left side?
When
You
we
have to
did,
mention both you have to mention.
we could feel the gap on both the sides of the masses.
That you have to mention. Able to
Okay, sir.
insulate the finger between the right
Insert fingers on
costal
both sides
margin and
on
the
top of the
mass,
mass.
left costal margin and the mass. You are rolling out liver as well as spleen.
Okay,
both
sir.
the, both the
Why that point is important?
If the suppose
if you're
the
not-
liver
Yes, proceed.
if it's a liver involvement, then we won't feel the difference. If it's a splenic involvement, we won't be able to insert fingers. The mass will go downwards into the abdomen. Yes, these two, liver and spleen, ruling out the causes.
Right, okay. Next slide.
liver. Okay. Intrinsic mobility is not that. Why transmitted pulsation? How to differentiate between the transmitted pulsation and expansile pulsation in the abdomen?
So when we put the index fingers on the abdominal transmit
You will
pulsation,
not be able to do that. Only in the surface will be able to do that. In the abdomen, you don't do fingers move apart like this. You don't do that.
okay, sir.
How to differentiate between the transmitted pulsation and this is the transmitted pulsation, no?
Yes,
So
sir.
how to differentiate it from the expansile pulsation? If it is expansile pulsation, what it means for you?
It's an abdominal aorta aneurysm involvement. Probable.
Okay. If it is transmitted pulsation, something else in front,
It's
compressing
not.
the.
Yes, sir.
So that is not the way to differentiate the finger. That is only for if radial artery aneurysm or axillary artery aneurysm or popliteal artery aneurysm, we can do that.
If you are holding a vessel and your holding fingers move apart, so that is expansile. You understand? You are holding a vessel, then that vessel, your holding finger, two fingers are moving apart means it is expansile. Whereas this one is different. The transfer means mass is above the vessel, so every time pulse the
Transmission is
swelling
coming.
moves.
Whenever you describe, whenever you palpate a mass, you are looking for two things about the mass, whether it is benign or malignant, by measuring the size, surface, borders, consistency, and other things will tell you whether it is benign or malignant. After confirming it, you have to go to the plane of the swelling. Plane we will discuss later. What about surface, borders, and other things?
You are not mentioned anywhere
You are
about
not, because smooth surface now we can think in terms of benign.
So it's in the previous slide. The surface and the borders in the previous slide.
That cannot be in the previous slide. You have to tell it in a particular order only.
palpation.
Height,
Order
size, shape. It should be in a particular order. You cannot change the order.
Order it should come first, early. When you
Yes,
say
it's in the palpation only in the previous slide.
the first.
This is palpation, right? Surface.
So it's in the palpation previous slide. There's two slides of palpation.
What about the surface?
So it
Surface
was
and
smooth and surface.
Borders ill-defined or well-defined?
The borders are well defined, but the lower border is more well defined. The upper border could not be made properly.
Whenever you mention about epigastric mass in the epigastric region, you can mention whether the lower border is rounded or not.
The lower border was rounded and well defined.
Rounded you have to mention, because
Yes,
if
sir.
it is sharp, it becomes liver or spleen.
Liver or spleen, yes, sir.
Rounded, it can be anything.
Okay, sir.
Specifically, you can mention lower border is rounded.
Okay, sir.
If you are able to palpate the upper border palpable, you are ruling out liver and spleen again.
Yes, sir, yes.
So everything is important. All the borders are palpable, lower border is rounded or sharp, surface well-defined,
Smooth.
borders are well-defined or well-defined, consistency.
Consistency.
After that only plane of the swelling.
Yes, sir.
why you want to look for falling forward? Mass does not change or fall forward in changing position.
If it's falling forward, it can be intra-abdominal mass, but if it does not, it means it belongs beyond the peritoneum, so it can be retroperitoneal mass.
Before that, you mentioned on head raising, read it out.
Both
On head raising, the mass is intra-abdominal and therefore
mass is intra-abdominal, correct? How do you know?
yes.
Head raising, you can say it is intra-abdominal.
It's intra-abdominal.
Intra-abdominal can be intraperitoneal or retroperitoneal.
Yes,
How to differentiate intraperitoneal from retroperitoneal? That you cannot mention it here. Retroperitoneal.
If it moves forward, it's intraperitoneal. If it does not, it's retroperitoneal.
Right. Any other point?
Any other point?
So retroperitoneal masses generally radiates the pain towards the back.
No, that's history. Palpation wise.
Palpation point.
Examination wise.
Mobility.
Intrinsic mobility.
Intrinsic mobility present, falling forward is intraperitoneal. Intrinsic mobility absent, not falling forward is retroperitoneal. So first point is head raising. Second point, intrinsic mobility. Third point, falling forward. If it is upper abdominal swelling, you have to mention about movement with respiration.
Okay, sir.
In this particular order, you have to mention, remove that retroperitoneal. Retroperitoneal is something different.
Yes, sir.
Not in that. Head raising, you are differentiating parietal mass from intra-abdominal mass.
Yes, sir.
Next slide. Okay. Is it the mass transmitted pulsation? Okay. Nice. Next. Whatever scar, it is adherent to the scar. Next slide. Next. Okay. Surface, and you are not mentioned surface and consistency. That's what sir told somewhere.
Sir, it's written in the palpation. Palpation
It
note
should be in a
first
particular
letter.
order. Height of the
Yes,
swelling,
sir.
size of the swelling, shape of the
Yes, sir.
swelling, extent of the swelling. Something
It'll
like
come
that.
after.
No, surface is smooth or not, then second variable. Consistency may not be same. So you have to say whether
Yes,
it is same or soft or cystic or variable. All those things you have to say.
Yes.
Okay.
So soft.
Liver dullness, general tympanic note over the abdomen, dull note over the mass, dull note over the mass.
The note is done, yes, sir.
You have mentioned liver dullness starts in fifth space. Where does it end? What is the liver span?
What liver span? Upper part of the liver and lower part of the liver span.
You only mentioned one margin, no? Upper border you mentioned starts in fifth space. Where does it end? What is the span of the liver? It is important.
Okay, sir.
You should mention that. Okay.
Okay, sir.
Percussionally, you have to mention the percussion note over the swelling is dull. The dullness not continuous with the liver dullness. There is a band of resonance between liver dullness and the mass dullness.
That's
Left
important.
side, you have to mention there is a band of resonance between dullness over the mass and the splenic dullness. You are differentiating it from liver and the spleen. Then you mention, as I mentioned, upper border, lower border. Band of resonance you have to mention. Then you have to, of course, you have to mention about ascites.
Yes.
That point is important. So dullness not to go along with the liver dullness is important. Not continuous with the liver dullness. That point is important. Okay. You have to mention. Okay. Normal person, left supported area.
The percussion note is dull. So that means there is nothing intervening. So where do you think the mass is arising from the front or from behind?
If you feel the bowel in front,
Sorry, sir.
you could feel the stomach in front.
No, we just felt the mass.
Well, the mass. Okay. What about scar? Scar is adherent to the mass or scar is separate? Do you hold the mass? You're not sure. Okay, no problem.
Not sure, sorry.
Not sure. Why left suprachiasmal lymph node you want to look for?
This is a metastatic mass. It's the first most common site for metastasis in lymph node is the left suprachiasmal.
What is that node called as?
Virtual lymph node.
What goes on?
What is the sign? What is the name of the sign?
Sign, what is that sign called? Malignancy causing second is in the virtuous node. What is that name? What is that sign called as? Srivas? Arjun, it's called a Troisier sign. Troisier sign. Okay, that's important.
And you have not mentioned anything about external genitalia. What if he's having a big testicular tumor with a big gastric mass?
External genitalia you have mentioned. They have mentioned, I think, in the description.
Not here, scrotum.
Scrotum, have you mentioned external genitalia?
No, sir, we did not mention it.
Examine.
Okay, sir, okay.
If you are not examining external genitalia, it is incomplete.
Because he can have a testicular tumor with retroperitoneal lymph node mass.
Yes.
You have to examine for testing. You have to examine. You have to mention that.
Okay, sir.
Okay? That's important. Okay. So go to the next slide. The order is important, like Muthukumar sir told no. Order is important. Why it is
Consistency.
intrinsic mobility and falling forward.
Yes, sir.
Position is not by a finger. It is by change in the position in the abdomen. You know the finger to find out that. Okay, that is what you are told is a wrong answer, Arjun. Okay,
Yes, sir.
change in the position, pulsation will disappear. Reduce intensity, that is called transmitted pulsation. Okay, in the abdomen,
Okay,
totally different method, not unlike in the radial artery aneurysm or puppet aneurysm. Okay.
Okay. Yes, yes.
Okay. Why rectal examination? Why you want to do rectal examination?
Sir, patient could have portal hypertension to see if any hemorrhoids are
or want to look for piles or anything else you want to look for? Anything else?
So the prostate is enlarged, or if it's nodular.
Because you have not yet come into conclusion that it's pseudocyst.
Yes, metastasis.
Maybe mets, what is it called as?
It's
Retrovesical second is what it is called as? Any name for what is secondary called as? What shelf it is called as? What about bloomer shelf?
Bloomers.
Bloomer shelf, yes, sir.
Heard Srivastava, how you heard? Not heard. You heard? Bloomer shelf?
Yes, yes, sir. Yeah, bloomer shelf, yes, sir. It's the area of metastasis.
Bloomer shelf it is called as, okay? That's what you have to look for. Okay?
Yes, Arjun, is your scar free?
Sir, I'm not sure what the scar attachment to the mass. I did not assess that.
Your scar, you are able to pinch the scar.
That's what I asked, sir.
I did not assess that.
Done that.
Sir already asked it.
Sir asked you before. Yes.
He should feel the scar and see whether it is identified or not. Always.
Is there any cough impulse over the swelling?
No, sir, government was not there.
You
Yeah, I will check. You have to mention.
Mention, you have to mention.
Impulse on coughing in the scar, okay, over the scar. It's also important. So many points which are missed, you should be able to use it. Okay. So we'll go to the next slide, sir.
Yes, sir.
Next. Other systems, central nervous system, spine, respiratory system, pleural effusion. Why effusion you want to check? Arjun, why effusion?
So patient has had a history of acute pancreatitis. So, and one of the complications of that is ARDS and pleural effusion.
Okay. Go to the next slide, sir.
Yes, sir.
The next slide. So summary, he has told all this so that the timing little different is there. Or 10 in 12 centimeter, tender, well defined but irregular border, tense, smooth surface, often consistency. Areas mentioned. Other system becomes normal. Okay, soft and sensitive.
Both pain and swelling 2.5 months. That is one thing, defect.
Yeah, yes, sir.
There is some interval between the onset of pain and swelling. That is very, very important.
Definitely there will be. Okay. So that is about the summary. Go to the next slide, sir.
Yes, sir.
So why you said pseudocyst, sir?
Other possibility, cystic lesions in the epigastric region.
Yeah. Yes.
Other possibilities, you tell me.
So it can be a left liver lobe. It can be
Very good.
cyst from
Very
the left
good.
liver.
Cystic lesion arising from the left lobe of
Left
liver.
lobe.
Liver. Very good.
Then it can be cirrhosis of pancreas. It can be cyst adenocarcinoma of the pancreas.
Come out of a pancreas.
Then
So it could be hydrated cyst.
Or gastric mass.
Parasitic hydrated cyst.
It can be from
Hydrated
spleen.
cyst.
It can be from spleen also. Any other cystic lesion?
Why can't it be spleen? Something like sir rightly told. Why it is
So
not?
we felt that it will to insulate the fingers over the margins. That's why.
Okay. Give some clinical reason. Spleen will move with the respiration, no?
With respiration.
Yes, spleen move with respiration.
It has got some intrinsic mobility. You can't get to the upper border.
Respiration.
Left frontal margin. It is obliquely placed.
Direction of movement is
Oblique.
towards the radial leg fossa.
Left to the right, left hypochondrium to the right till fossa, no? Obliquely placed.
Right iliac fossa.
Direction. But you have to think in the exam they'll ask why not spleen you should be able to do reason. Why not left lobe of the liver you should be able to do reason.
I am saying it is a mesenteric cyst.
So mesenteric mass will be mobile if you do because the mesenteric momentum is mobile. In this
Very
case,
good.
not mobile.
It is intraperitoneal. It is freely mobile, right?
Free mobile if it's a mesenteric or momental cyst.
So now your plane confirms the diagnosis.
Yes, sir.
Plane of the swelling confirms the diagnosis. What type of mobility you will get it in mesenteric cyst? I am indirectly asking the attachment of the mesentery.
What is the attachment of the root of the mesentery? No, root of the mesentery is only 25 centimeter, whereas near the bowel it is 6 meter. It fans like this. So what is the attachment of the mesentery?
No, whether it will move horizontally or vertically, that's all.
Horizontally.
Horizontally.
What is Tilloch's sign? Tilloch's sign, have you heard about it? Tilloch's triad, Tilloch's sign. In mesenteric cyst. Arjun? Srivastav?
No,
Not
no.
Tilloch's sign. Okay. Mesenteric cyst is a very common short note task. You should know.
Okay, fine. Okay.
4 types of so these things. Okay. Mesenteric cyst. Okay. Should be thought of, like sir rightly told, something else other than pancreas also you have to think of, you have to think widely. Other organ also you have to think of, like liver, spleen, and so on. It is not confined to one area and think widely in the abdomen. It's a magic box. No, abdomen is a magic box, Pandora's box. Okay. So a lot of things may become something else even after investigation. When you open it, may be something else. So you have to think widely in the different possibilities. Okay. So, sir, anything else to ask, sir?
No, sir.
Okay, so why you said pseudocyst? Clinically, why you said it's pseudocyst? You reason, no? Arjun?
It's a mass in the epigastrium which has arisen after a history of patient having acute pancreatitis. It's a common complication of pancreatitis based on history. It is a soft mass. It is soft in center but firm on the heart, which indicates it being having a fibrous covering on the outside, which is a pseudocyst. It is immobile but has transient pulsation.
Arjun?
It is also associated. It is immobile, having transient pulsation. The mass is soft in consistency, smooth surfaces, and lower border is well rounded and well felt. We are also able to insinuate the fingers on either side of the mass on top, which indicates exclusion of liver or spleen involvement. So that's a based on history examination. It can be a pseudocyst of pancreas as a
Not falling
complication.
forward, not moving with respect.
Not falling forward. So it's retroperitoneal. Also, head rising is intra-abdominal.
Why do you call it a pseudocyst?
Why you call
So
it a
that's
pseudocyst?
because it's not covered by the epithelium, it's covered by a fibrous layer.
No lining.
It does not
No
have
line, no
epithelial
line.
line. There's a fibrous layer outside.
Okay.
Okay.
So we'll go to the next slide, sir.
Sir, investigation.
Investigation.
So what's the investigation? Arjun?
So we should do ultra ECG abdomen can be done. CECT is done to know the exact location of mass, whether it's a solitary or multiple masses, the approximate size dimensions, the wall thickness of the mass, and size of the entire mass. MRCP, ERCP can also be done to know if the mass is communicating with ducts in pancreas. Then regular blood tests can be done to differentiate whether it's an adenocarcinoma or a normal pancreatic mass.
Why CEA you wanted to know? CEA?
CA is elevated in mucinous cyst.
Carcinoma
Just
cantina.
adenocarcinoma. It's associated with pancreatic carcinomas.
Which carcinoma?
Mucinous cyst.
Mucinous cyst adenocarcinoma.
Mucinous cyst.
Mucinous cyst.
Mucinous cyst.
Just take it. What's the idea of doing endosonography, endoscopic ultrasound?
Sir, using that we can aspirate the fluid, which you can send for investigations of amylase levels, lipase levels, and CA also.
Patient is jaundiced, so LFT becomes important.
Yes, sir.
Serum amylase lipase is relevant or not?
Yes, sir.
They are altered in
Pancreatic
pancreatic.
pseudocyst lipase and amylase is elevated, whereas in mucinous cyst it is not elevated. And
What about the fluid amylase? If you do endosonography and aspirate the fluid, will you send the fluid for amylase or amylase? Will you send what will be the fluid amylase level? The pseudocyst fluid, no? Fluid amylase level will be normal or
3 times.
very high?
Yes. It will be around 2 to 3 times lower than the norm.
It will be very high. Fluid amylase level in the fluid, it will be very high. Okay, fluid amylase is important. So, see, the MRCP they have told important whether it's communicating or not. So, is there anything else to add on to that? Manoharan sir.
Yes, sir.
Keshav?
Nothing, sir.
Nothing. So next slide. Next. Okay, treatment.
Endoscopic stent.
What surgery they might have done earlier?
So for that we have to see first if the cyst is infected or if there's any hemorrhage, we have to prefer external drainage. And if it is if it's sterile, then we prefer internal drainage. We have to do internal drainage, for which we can do cystogastrectomy, gastrostomy, or distal pancreatitis.
No, if they have done cystogastrostomy earlier, so what you will do now? What's the treatment now?
We can do a cystogastrostomy combined with drainage using a Malcott's catheter can be done. Like we just add a drainage, which is called the Smith operation can be done.
Any other option apart from cystogastrostomy?
Cystogastrostomy can be done.
It is based on the location of the cyst. You can do cysto. Otherwise, if you have to go for cystogenostomy.
If it is related to duodenum, we can do cystogenostomy.
Size of the cyst and location of the cyst.
Yes.
When will you intervene in pseudocyst?
So if it is more than 4 to 6 centimeters and if it's symptomatic.
What about duration?
If it's more than 6 weeks, with the size being more than 6 centimeters and the wall thickness being more than 6 millimeters.
Then only. Why that duration?
Because it may sometimes dissolve on its own so it won't have a sequel. So we have to give it the time until 6 centimeters it resolves. And based upon that.
How it resolves? Where is the collection actually? Pseudocyst.
So lesser sac.
Lesser sac. Disruption in the duct.
What is the
That may
color?
drain back.
Oh, okay.
What is the color of the fluid usually? Usual color, different usually.
Yellowish brown.
Brownish color, brownish black color. Okay. So indication already 6 centimeters, 6 millimeters. It will mature. Okay.
Only indication for urgent is if it is infected.
Infected. Yes.
Infected, you have to drain it.
We have to do external drainage. Okay. So pseudocyst is a common main question for undergraduates. Short note also, and exam they will keep a long case. Mass abdomen, at least basic upper abdomen exam. It's a very vast thing. So widely you have to think, sir. So that is important. So now when I put my slides, meantime, sir, any comments or anything to this?
Would you like to say this is acute pancreatitis or acute on chronic?
Sir, the patient had a long history of alcohol intake. So I think acute and chronic also. We can say it's acute and chronic pancreatitis.
Yes. Okay. Right, sir.
Okay. Put my PPT. Sir Muthukumar, sir, any comments on their presentation? Meantime, I'll start this one. Final comments.
The presentation is
very good.
Very good, sir. Very good, sir. Only thing is they have to concentrate on other aspects also. Instead of concentrating only on pancreas, you have to concentrate on other organs also.
Abdomen is usually a difficult case actually.
Yes, sir. Yes, sir. I did well, sir.
Difficult, and that Muthukumar sir highlighted that is important. How to intraperitoneal.
Yes, sir.
Order is very important. Order, way sir has told, very clear, important. Orderly, and Keshav has highlighted liver span, percussion on orderly, and Manoharan sir has told other points important, pulsation and other things. It is not a finger, okay, it's a change in the position. So that's also important. Okay, then you should be able to think widely, left lobe of the liver, spleen, and other things. Other organs also you have to think, other pathology also you have to think of. Okay.
Yes,
so regular must always. PR is in all patients. Yes, sir.
They did well, sir, but both Arjun and Srivatsav,
Yes.
you are prefixed with that pseudocyst. So you don't want to talk anything else other than that pseudocyst. That is the problem. So we have been telling you repeatedly, have open mind, and sir was leading you, tell some other diagnosis, other anatomical structures nearby, and all those things. Otherwise, discussion-wise, you are good. The only thing is you are carried away by the this thing.
Differential diagnosis, you must keep it in your mind.
And
2, 3 differential diagnosis.
each one you have to sustain why it is not. So like the movement of respiration is very, very important. Okay.
Yeah, that's important. And
Otherwise, run through is good. Both of you did very well.
We covered everything.
Thank you so much, sir.
anatomical and pathological part. Okay. So I'll just go through my slides, sir.
Yes,
Because
sir.
the main case for student. Next slide. Lavanya, next slide. So I'm not to detail it. These regions are important. These lines are lower transtubercular line and transpyloric lines are important. It is there in this. So that's how we'll do the lines. So in the exam they will ask this. Based on this only we'll check this one. Next slide. Next. So these are the quadrants. So regions are different, quadrants are different. So look, so this is in the midline, two crosses. Okay. Next slide. So you have to always imagine, and this one history, orderly fashion. That's what sir told. Orderly, you have to put pain, mass. It won't come together. Whatever it comes first, you have to put it like this. Satiety is important. Whether satiety is reduced or not. In malignancy, it may reduce. Jaundice, alter. Most of the things you have mentioned, but it's orderly should be mentioned. Next slide. Next, so I just put in the table all these things: mass, abdomen, pain, vomiting, satiety, jaundice, icterus, like dyspepsia, meanings of that. So hematemesis, why it is so. So past history of period surgery, whether drain placed, when they have removed drain, how long, how much content was coming, what type of drain, tube drain or corrugated drain. Although detailed history you have, when they have removed all those things. The detailed surgery history should be in detail. Whether wound got infected, whether patient was in ICU, whether rice tube was there, catheter was there, when they are removed. All those things are very important. Detailed history should ask. And treatment history, previous chemotherapy, RT, antidote drugs, personal history, family tree, already done. History of ulcerative Crohn's, pain malignancy, anybody else had in the family. 3 generation family history is important. You have to remember that. So just history in a box I have to remember. Next slide. Next slide. Next, Lavanya. So write brief summary always in case you do not use short form. That's important. So melena, this is jaundice. So always look for these things. Black tarry color stool. Okay. Next slide. Next. So next, continue. So all these things in general exams in the GA it's important. Whether they are emaciated in the advanced malignancy, emaciated, nourishment, cachexia, jaundice, nail, cavity, skin structure, respiration, generalized lymphadenopathy. Overall look in cachexia at least in basic other additional thing other than the BP for these things as far as GA malignancy or GA condition is concerned. Next slide. So again, there is supine position, bed exposing from both from the side and the foot, and you have to examine the patient. How to examine? This is the position. You have to expose properly and examine when you examine the abdomen. Next slide. Next. So palpation should be done from the right side of the patient. Patient should lie down flat supine. Patient is started away from the location always. If there is a epigastric region, you examine, start from the palpation from below upward. If it is a liver palpation from the rectal fossa, go upward. If it is in the spleen, from the rectal fossa, go towards the left side, like that. Away from the opposite side of or away from the suspected area. You have to start examining the patient. Next slide. Next. So this is inspection. Again, we have discussed the counter, symmetry, fullness, umbilicus shape. Tunnel sign, it is the umbilicus pushed upward or downward, all of you know that. Movement to the respiration, sir has already told. Scar, correct, whether it is primary healed by primary intention, secondary intention, and whether attached the mass or not, sir already told. Dilated veins in standing position. That's important. You have to mention dilated veins always in checking standing, swelling, sinus fistula, visible gastric peristalsis, visible intestine peristalsis, and visible colonic peristalsis, and visible pulsation, and visible mass, size, extent, movement in the respiration, surface, border. Already, all professors have discussed that the border is important, lower border is important, whether rounded or not. Hernial sites, Keshav has told actually, external genital is important. In this patient is very specific. In all abdomen, external genital should be examined. And left procalposa, anyway, you highlighted. Method is there is no superficial palpation in the abdomen. Remember, palpation, deep palpation. You'll never use word superficial palpation. Palpation of the abdomen and deep palpation. And one hand or two hand method. One hand is single hand, two hand is both hands you place it. And in the deep palpation, when you do both hand you can use. And tenderness, intercostal tenderness, abdominal wall edema in acute inflammatory condition, you can get palpation at individual regions depending on the location, you can check. And how to palpate for liver, spleen, stomach, colon, kidney, pelvic organs. And when you palpate, palpation can be done standing. After you have to conclude the thing by standing position, sitting position, after emptying the bladder, because in the lower abdomen mass, in the pelvic mass, you have to palpate after emptying the bladder to get the clear picture. Remember. So all these things are important. Sir told margin, surface, consistency, intrinsic mobility, falling forward of plane of the mass, pulsation over the mass, impulse on cuffing. Again, Manoran sir has highlighted. If there is a scar, and impulse is there, hernia is there, same thing is important. It's mentioned here. So dipping method, if there is ascites is there, dipping method to get the better texture of the mass, whatever it is. So this table will help correctly to go in order to examine the patient properly, impression and palpation. Next slide. Next. So all this is the visible gastric peristalsis here, large one. This is the dilated veins here with the umbilical hernia. The same patient's mass here. Another patient with the IVC obstruction, dilated veins in the lateral. So examine the standing position. That's important. And you look for dilated veins. Okay. Next slide. So this is the one finger, not one finger. It's a one hand actually. One hand, two hand methods. One hand, two hand method. This is the palpation. This is the palpation of the liver. Next slide. Next slide. So succussion flash and ascal percussion first. I am not detail it. In the stomach, you have to check like that. Next slide. Next. Lavanya, next slide. So spleen palpation, the costal margin, hook sign towards the left side, and all the different things which is there in the book, you can go through. So there are so many methods. Sometimes they will ask what are the methods used to examine the spleen. Next slide. Next slide. So head raising and leg raising, that's important to whether it's intra-abdominal or not to check. Next slide is the plane of the abdominal mass. And of course, other things Sarah has told already, intrinsic mobility and falling forward. Next slide. So renal mass in sitting position, already it is mentioned. And go back. Go back, Lavanya. Go back. Okay, different methods in standing, exercise or renal mass, ballotability, percussion, sitting position, bimanually palpable and ballotable renal kidney mass. Remember, bimanually palpable and ballotable. It moves with the respiration, renal mass. Remember, it's a retropetal mass which is moves with the respiration. And percussion always from the behind. Normally, renal angle is resonant and become dull when kidney is enlarged. Normally, it is occupied by the colon, ascending colon right side, descending colon left side. Okay, next slide. And different methods, example after passing urine catheterization in the lower abdomen, change of position, sitting, standing, already told. Next slide. Next. And liver dullness, percussion over the mass, free fluid thrill, puddle sign, Blackstone low test for the lower part, over in mass, percussion for phoenic dullness, percussion over renal angle, already I have told. Next slide. Liver span is important, already told. I am not going to detail it. Often it is asked what is trough space, castral sign. mainly for the upper abdomen mass, in the stomach, in the gastric mass, and other things. So the space is often it's important. It may be asked in the exam. Troughs space. It is by percussion. You can check it. Next slide. So left supraclavicular lymph node is a Reusser sign. We already told the level 4 lymph node. It is called a Devil's node, and suggest secondary is from GAT. And this is how exactly it looks like. Next slide. Next slide. Auscultation, all these things you have to look for: bowel sound, bruit overheard, bruit around umbilicus, Canaway sign. All those signs are important for MCQ question. Ausculto percussion test and succussion flash, already shown that also comes under that's what the gastric outlet obstruction and gastric dilatation. Next slide. And rectal is important, remember. PV also important in female patient, respiratory system, skull and spine, CVS examination. Next slide. So diagnosis like this, you have tried secondary in the liver, probably primary in stomach, differential diagnosis important. All these tests, MRI, depending on the situation, PET CT for the gastroscopy, colonoscopy, EES, guided FNSC biopsy in a liver, in abdomen mass. Depending on the location, region, depending on the what organ you think of, you have to decide about the investigations in this patient. Next slide. So treatment, drugs, intervention, surgery, laparoscopy open, adjuvant therapy, further therapy, follow-up. And these are the things you have to remember always. Remember, mass abdomen is a long case, dilated, detailed history and examination necessary. PR is a must think of this one. Treatment plan, treatment follow-up. So next slide. Actually, Lavanya, I have actually asked you to put the new PPT, which I added some more photos, which were not put. That's okay. Next slide. And so go to next slide. So that's a mass abdomen, which is important for the exam UGs, and it's a very vast subject. It is they have to go through the books, go through the different chapters to understand they have to repeatedly examine the patient for understand the logic of mass abdomen in different regions. Keep on examining thing. So my clinical book manual and my website, I request everybody to subscribe. It's free and go through all lectures, everything. And sir has written the foreword to my new book actually, Manoran sir. Thank you very much, sir. Always remember you. Muthukumar sir, thank you for joining always for all. I request you join regularly. Keshav, thank you very much for joining. Of course, did well, the difficult case. And thank you everybody. I presented well. It's a difficult case, and it's always an exam case for the case. It's always an exam case for mass abdomen. Okay. So, sir, thank you very much. Anything to add? Final thing, sir?
I think, sir, both presented well.
Okay.
Yes, sir.
They presented well. Best wishes.
Best wishes.
It's a long case.